Welcome everybody to the September 16th Chesapeake Rotary Club meeting. I appreciate everybody's attendance here today. If we could all bow our heads. Heavenly Father, thank you for this gathering today. Thank you for the food that is nourishing our bodies. Please bless those who are in need of your healing strength, especially our loved one, Sue Ann Hardy Bryan, and her family after the tragic loss of her child. We also pray for those who are in need of your strength today, going through difficult times, especially those dealing with the hurricane and the fires out on the West Coast. In Jesus' name we pray. Amen. Anthony Draper, could you lead us in the Pledge of Allegiance, please?
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Bob Morhusen, could you please lead us in the four-way test?
Sir, four-way test of the things we think, say, or do.
First, is it the truth? Second, is it fair to all concerned? Third, will it build goodwill and friendships? Fourth, will it be beneficial to all concerned? Have fun, sure. All right, you can be seated. All right, if I could ask our stand-in Sergeant-at-Arms to come up here, John Barrett.
Chuck's not here today. I'll put up with me this week. We've got a couple guests. Tom Dan, you want to introduce your guest? Oh, there we go.
My dad talk. I'm in the remember Diane.
Welcome, Mike.
And Henry Thrasher. Welcome. And Happy Bucks. Anybody have any Happy Bucks? All right. So. Oh, no.
What I posted on Facebook about a fundraiser for Dorothy Lee. She's a 15-year-old girl daughter of the local fireman. She's suffering from stage 4 renal medullary carcinoma. And on Saturday, there'll be a fundraiser, $10 for a full court dinner. But it does sound great. If you have any questions, you can at the door, or if you let me know, I can read the papers.
Anybody else have any Happy Bucks they want to share? Anything good going on? Good news? All right.
We need to come up with some good news during these difficult times. Just so you know, Sue Ann is very appreciative for all the support that she's received from the club. Obviously, it's a very difficult time for her, so anything that we can do to help, we will be here for her. And I certainly appreciate those who showed up, the visitation as well as the funeral services today. So thank you for everyone for doing that. All right. If I could have Debbie Ritter come up and introduce our esteemed guest today.
Good thing, Debbie.
I appreciate being able to introduce our guest today. Last week, we were blessed to have Mike Barber come. Today, we're doubly blessed to have Dr. Nancy Welch. I could go through Nancy's CV, and you all would be incredibly impressed with her life and her story and all of the things she has done for the city. But I'm sure at this time, she's going to bring you some very interesting, factual story, the interesting and factual story as the city and the region deals with this pandemic. All I can tell you is we're so fortunate to have Nancy. She has a pragmatic, data-driven approach. She's calm. She manages to cycle between hysterical people on both ends of the spectrum, and to deal with them with a great deal of grace and knowledge. And we're just really lucky to have Nancy be the real leader in this whole pandemic response in our city. I always like to thank you personally, Nancy, for every time I watch you, I learn something. And I've had an opportunity to preview what Nancy's going to tell you today. And I think it'll help you cut through many of the questions that you have. And I will say, all of you sitting in this room probably at some time or another go into the category of, we don't pay attention to what she says, meaning me. But I've tried to give some advice. I think the people most affected by all of this, aside from our older folks in our businesses, are parents with kids in school. And, you know, I would bet 70% of them take their information from social media. So I'm hoping the approach that our city is using, and I wish the school board followed us a little bit more, is to involve Nancy in every discussion, because she would be able to quell the fears of people. So Nancy, we welcome you today, and thank you for taking a little bit of your time to come and speak to this great group.
Debbie, you're awfully kind. Thank you. Thank you very much.
Well, I wish I had an hour to tell people how wonderful you are.
Oh, no. That would embarrass me, and they have better things to do. It's a real privilege to be here today, and I hope that there can be questions and there can be greater illumination on what we're doing. I've been in public health now for 44 years. I was on the mountainside for 11 years, from Roanoke over to West Virginia. And in public health, we're accustomed to large, major public health events. I mean, we've dealt with hepatitis A and food handlers who's exposed thousands of people, so we have to get in and provide intervention, or active TB disease and a healthcare worker who subsequently died and exposed close to 3,000 people, or measles and a football player who happened to expose all kinds of people at college during homecoming weekend. So public health is accustomed to mass events. For H1N1, we gave 40,000 vaccines. The mass event component of COVID is not the concern. I'm going to share with you some of the things that is what makes COVID so different from all these other things I've mentioned, and from all of the experiences those of us in public health have had. And then I hope that we can move into the data. I am very data-driven. Debbie's science-oriented as well, so it's nice to communicate and share these things with her. First and foremost, COVID is totally new. I know people don't like to necessarily hear that, because they like to hear about something at the beginning and have the information at the beginning be the same as what it is 3 weeks down the road. But COVID is indeed new. So the first thing that those of us in public health who were expected to know about this thing had to do was really rev up our reading and read every single experiment, every single scientific thing that was out there, so we could know about COVID. It's not the first coronavirus. There have been other, like MERS, Middle East Respiratory Syndrome, that was a potential pandemic. However, MERS was not as smart as COVID, and I do have a tendency to sort of make them almost human, smart or dumb. MERS had a 35% mortality rate, which, if you wanted to become a pandemic, was kind of dumb because it killed off its host. So it couldn't spread very well. COVID learned from that, and so its mortality is not as great, and that is what has contributed to the pandemic state. Because yes, we have a higher death rate than flu, but we have lots more people who get it who don't die, and so it spreads pretty easily. And that's why certainly the precautions are being taken here. So it is a totally new, we learn new things about it almost every day. And when there are changes that occur, it's not because there was a goof at the beginning, it's because decisions were made based upon what was known. For example, at the beginning, similar to other communicable diseases, it was not felt that asymptomatic, except maybe 2 days before you became sick, you would be contagious and spread it. But now we know that 30 to 40% of COVID, contagious, asymptomatic. So that puts a whole new dimension on COVID. We have absolutely nothing in the communicable disease realm that is comparable to that, of having so many who are asymptomatic but yet contagious. Most of these contagious, asymptomatic folks, when we map it out, are the 20 to 49-year-olds. And of course, we've seen that with some of what's occurred at the colleges. But that is certainly a bit of totally new information, and information that has been confusing to the public, but it's an earmark of being new. The second unique thing about COVID is that all those types of public health mass events I mentioned to you, the TB, the hepatitis A, the measles, there were interventions that we could do to stop the spread. There were vaccines, there were medications, there were interventions. Our challenge was just to get people in, to have the mass opportunity to be able to provide that intervention, vaccine or medication, to stop the spread. We don't have that with COVID. We do not have a medical intervention. We don't have a vaccine yet that we can do a mass event and prevent the spread. The third unique thing is that, and it's a follow-up to the second unique thing, is that because we don't have an intervention, COVID, and we've not had this with any communicable disease, is totally behaviorally focused, behaviorally driven, and behaviorally controlled. And that's a lot of why I didn't go into psychiatry. I'm not into this. I like more facts and things that we can control. We have absolutely no other disease that is, at this stage of the game, so totally dependent on behavior. What we've got is truly each other. New necklaces. What we've got is each other. Because we do not have the medication, we do not have the vaccine. And as Debbie has said, there are so many variable opinions, reactions, responses, especially on social media, that it is hard to focus on the behavior, the consistency of behavior. That is what really saves us, and has saved other countries that don't have as much of a reaction to some of these behaviors. Denmark, Japan, South Korea, there are numerous of them. And they have demonstrated how indeed these behaviors can make a difference. What I want to do today is to provide just sort of a general run-through on some of the data. You know, in public health, data is kind of our comfort food. We rely a great deal on data. We depend on data. We make decisions on data. We analyze that all the time because it is objective, and it is what we can gather from the information to help guide us. I'm not saying it's the only thing we use by any means, because in public health sometimes just having that personal connection and ability to get personal information helps us solve a lot of problems. But we rely a great deal on data. So what I want to do now is just present to you some data. Please ask any questions, because I know there's lots of confusing information out there about data. And so ask any questions that you want at any time. What I want to show you first is just some Eastern region data, because I know that districts are using a lot of Eastern region data that was decided sort of with a combination of localities saying, yes, let's use Eastern Region so we have something common among us that we're using. I would tell you that, yes, I use Eastern Region data, but I'm more focused on Chesapeake data. This is our family. This is our community. I'm more focused on that. But I do want to share Eastern Region data, and I think actually you see that in many respects we are improving better than the Eastern Region. One thing that I want to show here, and I'll use Eastern Region as the example, it's also in Chesapeake. I'm going to talk about positivity rate when we get to Chesapeake even more so, because positivity rate, this surge that you see at the beginning is when we have limited tests, we could only test those who had symptoms. Is anyone surprised that when you're testing only people who have symptoms that you have more who are positive than when you're testing everybody? So this surge was to be expected, but it is difficult sometimes to explain then why we had a big decrease. What was the difference? Well, the difference was we had more tests, and we did more testing, and we could test anybody. But initially, we could only test those who were positive. What that low curve, and this is true for Chesapeake as well, is called flattening the curve. And this is when we had restrictions, when we really emphasized there were restrictions with regards to facilities, with regards to capacity, with regards to masks, etc. But this is the Eastern Region, positivity. This is Eastern Region as well, but what I rely on, and I'll share with the Chesapeake data more so, is this is a weekly incidence rate. Incidence means new cases. And this is new cases for a week. It's calculated for a week. And as you will see with Chesapeake as well as the Eastern Region, we were sort of at a flat curve, then it increased. You can do these surges, you can look at your calendar, and they're related to when restrictions were eased. And that gets back to the behavioral thing, because this is totally behavioral and controlled, is that when restrictions were lessened, and this is not just for Eastern Region or for Chesapeake, it's throughout the state, there seems to be an increase in laxity, as if now we sort of can do whatever we want. But you can see what happens. And this is on the bottom is what's called the dashboard. And in essence, this again is Eastern Region. The top one is the daily incidence rate. I rely more on the weekly, and I'll show you that on Chesapeake. What's on the dashboard now is just the daily, that comes from the central office. But they, at our request of many health directors, are going to start including the weekly, because the positivity rate really is not as valuable now as it was initially. But what the dashboard shows us is the goal is to get down to the green. You know, green is good, dark blue is bad. So this is how we watch our trends. And for me, I don't look at a single data point, I'm interested in the trend. And there are a couple reasons for that. One is you probably read in the paper today or heard on the news about the increased number of deaths that were reported. This is an example of why we look at trends, because the deaths are not reported until the central office team has been able to go through all the death certificates. That takes time. And they have to confirm things. So some of this data is not, it's way later than the actual occurrence. So you really want to look at trends. This is just a snapshot. Again, I'm sure it's changed by now because it changes on a daily basis, but this is the latest compilation, meaning latest being yesterday. A snapshot of Chesapeake, a little over 4,000 confirmed cases, 54 deaths, and they have been primarily 60 or above. We had one in the 40s, but comorbidities was associated with them. 372 hospitalizations, 18 outbreaks. They have again been primarily associated with long-term care facilities or with correctional facilities. The number of Chesapeake residents tested is over 52,000, which is about 21%. We are on the high end of the percentage of our population that has been tested. Positivity rate noted at 6.2%. I do want to comment about testing. We have backed off on some of the testing. We started backing off because it was taking too long to get test results back. And so from a clinical medical perspective, it was of little value. You don't want a test result 5 days down the road. Well, you now find out the person's positive, and so they've been spreading it to everyone. But we have backed off because we are understanding the value of people understanding what's so important about the mask, what's so important about the 6 feet. So we are now building up more community events that are not test related, but they're related to providing masks, they're related to providing information, of hand sanitizer, of being there one-on-one to answer questions so that people can be informed. And we're hoping that that can help to contribute. Because remember, the test is just one point in time. Test has its place. I'm not saying don't test. It has its place. But we have to remember it is one point in time. You can be negative today and you can be positive in 2 days. And now there are so many tests out there, and the sensitivity and specificity is so varied that there can be a wide range of false negatives. And that doesn't help us either if the person is out there positive and spreading it. Let's look at some data. Okay, this is the positivity rate in Chesapeake. What is positivity rate? Positivity rate is basically the number of positive cases that you have from the total number of tests. So that means that the accurate result has to have the total number of tests be accurate. Total number of tests is total positives plus total negatives. There is no in between here. So that worked fine at the beginning when we only had a couple labs and when we're not doing as much testing. Now we have a number of different labs and we have several different tests, and they are submitted in paper form to Richmond, which then puts it electronically, and then it's fed back to the locality. With so many tests, so many labs, what started happening is people understood the value of positivity. If a test was positive, they wanted that to be reported right away, because we do contact tracing. We have about 20 people now doing nothing but contact tracing, so that we can help the people decide they need to be quarantined, isolated, further followed up in any way. But so the positives were being reported, but not the negatives. So until later, a few days later. So it meant that our positivity rate was inaccurate because our denominator was inaccurate. The mayor really nailed it the other day on Roundtable when we were talking about it. And he said, oh, it's like a batting average. He said, you can't just include the hits, you got to include the strikeouts. And he's right. He's absolutely right. And we were not including the strikeouts in a lot and every day. So that, where the strikeouts might have been from 4 days ago, but the positives were from that day. So there's a lot of controversy now over use of the positivity rate. Yes, I'm very glad we're seeing a trend going down. Again, as I said, I look at trends. I'm not going to depend on just a one-day thing. I want to look at trends. You can have little blips just because of reporting of the data, but that doesn't reflect the community. But yes, we are seeing a downward trend. You will see our upward trend was certainly associated with when we opened up more in terms of restrictions. Our downward trend started primarily when we then had the restrictions reimposed. So yes, it does relate to our behaviors. But this is, as I said, I look more at incidence rate. This is from the dashboard. Incidence rate is the new cases per 100,000 population. The denominator is constant. This is a common way that we look at lots of epi data. Infant mortality, for example, is deaths per 1,000 births. You sort of establish a denominator figure mathematically that forces as if every single community just had 1,000 births, say, when you're looking at infant mortality. Now, with 100,000 population, it mathematically is established as if every single locality had 100,000 population. And there's a mathematical way that's very reasonable that one does that, that takes your actual figures and then converts it to per 100,000. And what that means is that it's then more reasonable to compare. Because if you can't legitimately compare or look at, say, Portsmouth with Virginia Beach, because the sizes are so different. But by having this common denominator mathematically that puts the figure as if Portsmouth has 100,000 population and Virginia Beach has 100,000 population, what would be the new cases? And so that's what the incidence is. The other beauty of the incidence rate and is that not only are you establishing that common denominator, but you only have to know the positives. You don't have to know the negatives. So you are not dependent on reporting of all tests, which makes it much more accurate, and people, the labs and everybody are much, much more inclined to report the positives because they understand the value of that in terms of communicating with the individuals. So the incidence rate is usually much more current and it's much more accurate. And it permits us an opportunity to also look at, we can compare it with the region, we can compare with Virginia Beach, we can compare with the state. This is the dashboard which right now is using the daily incidence rate, but because there's been so much increased interest in the incidence rate among health directors throughout the state is now going to also add the weekly incidence rate, which I really prefer more. We've been using the weekly incidence rate because we've had some other folks who are involved in calculating it for us. And so that is really what we rely on. It's more current, it's more reliable, it's not dependent on the negatives being reported, which has been the biggest flaw on that. And this is Chesapeake incidence rate per 100,000 and the percent positivity, and this is from just a couple of days ago. Again, the key here is looking at the trends, and we're going down towards the green. That is what's most important. And of course now we've just recently had the restrictions again lessened, so that we're going back to some of the earlier phases. So the key will be, are we going to see a change? So far we haven't. We also are opening up the schools with a whole lot of attention to watching how they do. I will say that we literally just hired, she started yesterday, a full-time epidemiologist who is devoted to the schools, public and private, and daycare centers. She will not be dealing with any of our other, communicable diseases of all nature are still happening, but she will not be dealing with any of that. She will be totally dealing with just the schools and the child care centers, because we feel that that is so very, very important that we have close connection with that. So she was just hired yesterday, and she's already been busy connecting with all of the public and private schools. I will say that I really want to commend the schools. They've done a great job in terms of focusing in. We meet from the School Health Advisory Board on a regular basis, and they are really serious and conscientious about implementing. I would say that the private schools have not had as close and as stringent and rigorous oversight. So this is another reason why we have hired this epidemiologist who would devote herself just to the schools. Fortunately, she also was an educator before she became an epidemiologist, so I think she can relate very well to the teacher situation. So we are excited about that. We're the only one in the state that has done that, but that person will be the school contact and will be right there and is making connection as we speak, literally. This is another way of showing. This is again the rate, and it's a daily rate. The thing I want you to see on this, and you may not have picked up on it, we have a little bit of competition at Virginia Beach, right? Virginia Beach is starting to move up a little bit on that tail part. We're still staying down, so we like to sort of banter back and forth about that. But this is Chesapeake, the city of Chesapeake. Whoa, what happened? Whoa, didn't like me. It says, here's what I held while you were on full screen.
May I ask a question?
Absolutely, absolutely.
I know you're primarily interested here in Chesapeake, but have you had an opportunity to review the statement by Dr. Lee Ming from Hong Kong that purports to explain to us very carefully how this was not from the back. It was actually engineered in a lab. Have you had an opportunity to read that research?
I've seen various responses to that research, so I'm not convinced one way or the other, to be perfectly honest, because I have seen different studies that show different things. So to be honest, its origins are not as important to me right now. I'm willing to let that wait until the end. Right now I want to save lives. I want people to not be sick. And I'm a firm believer in getting back to a strong economy. I have an MBA. I understand the economy. I understand the business world. We can only do it, though, if we do it safely. And it doesn't make a difference if it came from bats or from something else. And like I say, I've seen a lot of controversial papers on that. Right now, our focus, rather than worrying about where it came from, has to be on saving lives, getting our economy back to a reasonable state safely, and our school children. We need to do that, and we need to look at those who are at risk. And those are the things that we're really focused on right now. I'm sure there'll be other studies down the road, and that will be interesting to learn. Right now, I'm interested in the practical side of it.
Do you have any positions in this area that you have Dr. Olson?
I'm sorry, say that again?
Do you have any named positions in this area that you have Dr. Olson?
None that I'm aware of. And again, there's certainly been some controversial studies as well, and none that I'm aware of. That's not to say there aren't some who are doing it without publicizing it, but I'm not aware of anyone who has promoted it here in the area.
How are our numbers compared to the Rona area, Western Virginia?
Ooh, good question, and I have not looked at it, but and we, as health directors, we communicate frequently every day, and the communication from Dr. O'Dell, who has been the pandemic person in the Roanoke areas, they have had a fair amount of outbreaks with the long-term care facilities, more than we have here. That has been one of their major problems, is the long-term care facilities. I don't know where they are in terms of the school. That hasn't come up in our conversations, but certainly in terms of the outbreaks. They have also been without a full-time health director for a while. A new one was just recently hired, so I'm sure that's going to help as well.
So, with all the contact tracing that you're doing, have you been able to identify the sources of the outbreaks? Is it inter-regional travel? Is it lack of masks, or is it all the above? I mean, what have you been able to do?
Initially, it was actually the bars and activities, and our environmental department, and I would tell you, I really like education. I'm a firm believer that in most cases, and certainly we've had lots of cases over time, not just with COVID, but with other situations with restaurants and food handling, etc. And we have a tendency to be able to work with the folks and not close as many restaurants as some areas. I'd much rather we spend the time working with them and educating them. So initially, there were some bars and restaurants that were definitely exceeding capacity, were not having masks, and were definitely exceeding the physical distancing. And there were lots of complaints. There's a central place where you can register complaints. It all comes down to the locality. So we get that on a daily basis and register it. And if we had more than 2 complaints on a location, our environmental went out. They would go on a Friday night or a Saturday night. I mean, this is when the folks are there. Why go, Tuesday at noon? So they would go when the complaints related to it. And initially, that was the concern. I would say, for safety's sake, I always have to think about the safety of our employees. And so they spent some time being educated by the ABC agents, and they would go with the ABC agents to these locations. The ABC agents are armed. And if there was a problem, the police were just notified. They stayed apart, stayed away, but they were there. And our staff and the ABC folks went back to the car and drove a distance away until the restaurant or bar could vacate the premises, and then they would come in and set up a plan for them. So that they could present a plan of how they could change the structure of things that they could do. And I'm not sure that they implement the plan. We didn't remove their license initially. I want to give them a chance to correct the problem. And definitely, almost all of them corrected the problem. We've had some where we've had to suspend the license, but within 48 hours they come up with a plan, they implement it. I'd much rather they do that. That's been our focus. But lately, come summer, what do people do at summer? They have family reunions, they have cookouts, they have social gatherings, and that, from our contact tracing since the summer, is the big thing, not the restaurants. So we have seen a change. Initially it was bar, but since summer and holidays, we're tracing them back to the gatherings. People have family reunions and they say, well, Aunt Jane, I don't need to wear a mask, but you've only seen Aunt Jane 6 months ago and she lives in Richmond. This is like a stranger. You still need to be 6 feet apart and or wear the mask. Because we do know this is a droplet. Thank goodness it's not, although there are some studies that show it might be aerosolized, but primarily it's a droplet. So the mask and the 6 feet makes a difference. So that has been our big thing lately, has been the social gathering, more so than the bars. They're catching on, the bars and the restaurants are catching on, but it's the gatherings at individuals' homes or at the beach or different locations, parks, where they have 20, 25, 30, 40 people, and they're not wearing masks, and they're certainly not abiding by any 6 feet.
How is flu season going to affect this COVID?
Boy, that's a tough question, and we don't really have a good answer, because the problem is that the symptoms are pretty much the same, with the exception being for COVID. It's not the most common, but they can have loss of sense and taste. You don't see that in the flu. But otherwise, the symptoms are pretty similar. And the reality with flu also is that you don't test everyone who has the symptoms. Doctors don't want them coming into the office and transmitting disease. So you go a lot by symptoms. And so whenever we say how many people have flu, it's based upon, we have surveillance locations. And then you do projections based on those surveillance as to the number of cases. But now it's going to be very difficult. The doctors are going to continue to try and say, talk on the phone and say, okay, I think you've got this. But the problem is, with flu, we do have a medication, Tamiflu, which can reduce the symptoms and reduce the length of time that you're sick. We don't have anything for COVID. Well, if everybody starts assuming it's COVID, then people who have flu are going to get Tamiflu. The flip side, what does Tamiflu do to COVID? Nothing that we know of. Is there any adverse effect? We don't know. So we are still debating how to handle that, because that's going to be a real tough question. And for the clinicians out in the community, that's going to be a real tough question, because they don't want either of them coming into the office, no one blame them.
Do we know whether flu would be considered a pre-existing condition which could lead to higher mortality rates with COVID?
So far we don't have information on that, but if someone got both at once, and nothing says you can't, I would think that the mortality and the risk of hospitalization and serious illness would certainly increase. Can I say I'm founding that on any research? No, I can't, because we're just now moving into that season.
Can you comment on the COVID-wise app?
I'm sorry, pardon?
Comment on the COVID.
Oh, yes.
App. I downloaded it, but I do get the weekly reports, but not enough people have it.
Yeah, the COVID-wise is the way that it maintains anonymity. I have it on my phone. It maintains anonymity, but if you test positive, it will send messages. I mean, you have to press the button, and it sends message to people who will, by their GPS readings, have been within 6 feet of you. It doesn't say who the person was that may potentially have exposed you. It does not reveal any identifying information. But it lets an individual know that they may have been within 6 feet of someone who is positive. The benefit of that is that then we can suggest that that person be quarantined. Let me, and that brings up a good point, let me point out the distinction between quarantine and isolation, because that's always a confusing thing. They relate to aspects of a disease. Isolation is when you have the disease and you're isolated during the time you could be contagious. So it's related to the contagious period of the disease, of when you could spread it to others. Quarantine is when you've been exposed, and is related to the incubation period, the time from exposure to the time of when you can get disease. So it's a different kind of a consideration. We know that the usual incubation period for COVID is 5 to 7 or 10 days, but we extend the quarantine out to 14 days to be sure, because there have been some cases transmitted within 14 days. Isolation is when you are, as I said, have the disease and you're contagious, so we want to keep you isolated at that time. And one thing that's been confusing to a lot of people is that we know that contagiousness, again, you're usually only contagious for at the most 7-10 days, actually not even 10, 5 to 7, but your test on the molecular test, the PCR that many people may be familiar with, can test fragments. It doesn't mean they're live fragments, it doesn't mean they can transmit disease, but it can detect those fragments for up to 3 months. And that's caused some confusion or concern, but they're not transmissible. So we stick with the 10 days. But the value of the COVID, it doesn't cost you just, and it's totally anonymous, is that it means that if you get a notation, then you can quarantine yourself for that 14-day period, the incubation period, that would relate to the time it will take to get the disease. We don't recommend that you go and get tested immediately, because remember, a test is 1 day. So you can have a negative test simply because there hasn't been a long enough incubation period. So we really go more by symptom. Yes, I understand 20 to 49-year-old are a lot of the asymptomatic, and that's where we get into the behavior issue. But we really go more by the symptoms than the test, because it can literally change from one day to the next. Deborah, did you have a question?
I just wanted to briefly, there's been some controversial discussion with the announcement that health departments via the state are being asked to develop a plan for people to get the vaccine when it is available. Do we still do our drills? And I think that might be interesting for people to know that you have a group that has a plan for this.
Well, we can do those mass things. I mean, like I say, we get 40,000 vaccines with H1N1. Mass, we know how to do. And in fact, nurse manager who pretty much pulled together the large H1N1 and has been with public health for a number of years, is on the state committee to develop the organizational structure for doing a mass immunization. A lot of the mass immunization is establishing the phases of who will get it when, and that relates to risk. And that's being discussed because there is some controversy about who should get it when and who should be in the first phase and who should be in the second phase and third phase, because we're not going to get all the vaccine at once. And there are a couple of vaccines, and we don't know which one we're going to come out with. I will be honest, I really think we have to be patient. We have to be sure that it's properly tested. For example, they're now seeing more stillbirths with pregnant women who get COVID, but none of the vaccines have been tested in pregnant women. And some of you are old enough, you may remember thalidomide babies from the 60s, 50s, 60s, and that was related to a medication that had not been tested in pregnant individuals that controlled nausea and ended up being given to pregnant individuals. And children were born without arms and legs. So we really have to be sure that we have appropriate testing. We have to be patient to get the appropriate testing. The last thing we want is to use a vaccine too soon and we get adverse side effects, then nobody's going to come to get the vaccine. And I don't want that. I'd much rather be patient, get the vaccine later, but have more people get the vaccine than have people scared. So yes, we are already working on how we will organize it, even looking to the extent of where we store. Some of the vaccines require dry ice, some don't. There are a number of different types of vaccines right now, and most, there's one that doesn't, but most require a booster. So it's not only organizing the first vaccine, but it's getting the booster in a month. So yes, we're already working on that. Do we have experience doing this? Yes, we do. I'm not concerned about that because we have a lot of experience with that. And every year we have to do, through emergency management, we have to do an exercise where we have done exercises of drive-throughs, and this would probably be a drive-through actually. We've done exercises of drive-throughs, we've done exercises of people coming face-to-face to get immunizations. We've usually done it with the flu, is how we've done it. H1N1 or the flu shots. So that we're accustomed to doing. My concern is more that I don't want us to be put in a position of doing a vaccine before it's been properly tested. Because then I think we're going to end up with less people being protected. Thank you very much.
I know we have run over a little bit, but I can't imagine a better topic to run over on. Thank you very, very much, Dr. Welch, for coming here and sharing your knowledge with us. I'm sure we're all going to be taking away quite a bit of good, and hopefully we can beat this thing at some point. Thank you very much. Next week we have our Commonwealth's Attorney Nancy Parr, who will be speaking with us. But other than that, if there's nothing else for the good of Rotary, we are adjourned.
Thank you very much.
Well, thank you. It's just a whole lot of information to try and get in there. The more people who learn, the better they can spread it to other people. Yeah, it's the education. That's what we got to finish. Good thing, Sherry.
Well, they were talking about these studies, but this is an ongoing topic.
Well, when we get the